Thank you, everyone. Welcome back. Today is World Fertility Day, and our next speaker is Dr. Van Waart. Dr. Van Waart is a fertility specialist at the Wijnland Fertility Clinic that is out in Stellenbosch. And we're very honored to have Dr. Van Waart. Today we're speaking about male infertility. Welcome, Dr. Van Waart.
Good evening. It's very nice to be, and thank you very much for the invite. What I think I'm going to try and do, sorry.
No, sorry. I was just saying it's a pleasure, doctor.
No problem. Thank you very much. And I think the talk tonight is going to be about male fertility. So what I've done is I'm going to try and share my screen. I've got a few slides prepared, and I think it's going to make it a little bit easier to chat. So I'm going to try and share my screen quickly. So
awesome.
You see. Let me just put it on full screen. Okay. Right, so I'm just going to have to go up. This is the last slide. So let me just go up to the... I'm just going to try and get the first one quickly. There we go. All right, can you see my my slides now?
Perfect, absolutely perfect.
Okay, so I think the factor of male fertility is really coming to the fore nowadays. And I think it's, in terms of World Fertility Day, it's probably a good place to start. I'm going to talk a little bit about male fertility, and then just one or two things I think which is quite interesting about the future. This goes a little bit wider than just male fertility, but certainly it complements that. So I'm going to say a few things about definitions, something in general, then the male fertility, and then also the future of fertility, which might be quite interesting. So the definitions that we start off, primary infertility is when a female has never conceived. Secondary fertility is we had at least one previous conception. And infertility is normally inability to conceive after 1 year of adequate sexual exposure. The incidence is about 1 in 6 of fertility. And as you can see, abnormal sperm accounts for about 36% or 1/3 of the reasons for fertility problems. What are the most common reasons that it happens? And I think from the male side, it's what we call teratozoospermia, or normal forms of sperm being less than 4%. The conception rate per cycle, I think we must remember, is approximately 6 to 10% per cycle. And that's actually independent of how hard you try. You must just be sure that your partner ovulates and that you try at more or less this right time. So the chance of conception after 6 months is about 40 to 60%, and after 1 year, only 85% of patients, if they do everything correct, will be pregnant. So the good news is that if you have the problem of fertility or infertility, then 65 to 70% of patients seeking medical help will be successful in having children. So a few things in general that I think we must remember, that at female age of 40, 3 out of every 4 eggs that is produced will be abnormal. So 1 in 4 will be normal. Male fertility, however, is not affected so much by age. There are 1 or 2 things that you should know if the male partner is older than 50, but fortunately, males do not get punished as hard as the female ovary. Female infertility, just a quick reminder, that's what we deal with. Specialist treatments available if you have male fertility includes intrauterine insemination, or IUI, also ICSI, or intracytoplasmic sperm injection. As far as male infertility is concerned, 35 to 40% couples would have a male factor, and this would affect 5 to 10% of male couples. But we do know that male fertility or infertility is offset by an increase in female fertility, and also vice versa. So you have a very good sperm analysis. It can make up for a little bit of anovulation in the meanwhile. If you have poor male factors up to a certain point, you really have a fertile female, or you help them to make more than one little follicle, this can actually help in offset that. The definitions, we get to definitions. Normospermia is normal parameters of sperm. Oligozoospermia is when the sperm count is less than 20 million per milliliter. And the other important one to remember, as I've indicated earlier, is what we call teratozoospermia, is where less than 4% of the sperm actually is normal. This is the difference, just a picture of a normal sperm on the left-hand side, the G pattern, or we call it the good pattern. Then the P pattern, which is the poor pattern. You can clearly see the difference in the head of the sperm. And the guys on the left certainly has a better chance of giving you a baby than the guys on the right-hand side. How do we classify male infertility? We normally would do that in 3 levels. The one is pre-testicular. So in other words, before the testicles, and that would very often be hormonal problems. Then the testicular ones, that interferes with the production of the sperm. And then also the post-testicular, and this most commonly would be some kind of obstruction that stops the sperm from getting ejaculated. The most common causes of male infertility will be a varicocele or varicose veins in the testicle that increases the temperature where sperm is actually produced. Remember, sperm will be produced normally at a ½ degree lower than body temperature. If you have blood vessels running in close proximity to the testicles, the temperature raises to body temperature, and that impairs a number of parameters. Idiopathic is a very fancy word to say that we don't really know what the reason is. And obstruction actually accounts for 14% of fertility causes or infertility causes by males. If you see the patient now, there are a couple of things that's really important. Firstly, quite a concise and a detailed history. The physical examination is very important. And then the special investigations of with the basic sperm analysis is most important. There are other specialized tests that one can do, but I think you must do a basic sperm analysis to get closer to an answer. From the history, it's also important that couples should be aware of the fertile period so that they try at the right time. There should be adequate intercourse. We would normally say every second day around about ovulation. And then one should also be sure that there's ovulation on the female side, which most often will be indicated by regular periods. The physical examination is important to make sure that we rule out any abnormalities there. The basic sperm analysis entails doing a count, motility, see how many of the sperm actually is motile, see if they swim in a forward direction, and also the morphology, which means looking at the percentage of normal sperm. I think very important that we should not rely on one abnormal analysis because it can sometimes just be a bad day at the office. So we should repeat it 2 to 3 months after that to ensure that you get a correct diagnosis. And I think when we share the male fertility or parameters or the results with males, we must choose wording very carefully. And I think if you are uncertain, you have abnormalities, make sure that you get an expert to advise you so that you give the correct words, because choosing the wrong wording can actually cause a lot of harm to males. How can one improve the quality of ejaculate? I think most important here is lifestyle. Restricting smoking, not excessive alcohol use, make sure there's adequate rest, have a proper diet, treat any underlying disease, avoid tight underwear. In other words, try and keep the testicles away from body temperature as much as possible. And there is some hormone therapy that one can do, but that should only be done by experts. What are the special investigations when you interpret a sperm analysis? The morphology, as I've noted before, but the concentration or the count, we would like that to be more than 10 million per milliliter. Along with the morphology, those are the important ones. The morphology, or the assessment of the percentage of normal sperm, is an art that the embryologist or the andrologist learn with time. The ones we use is the Steigerberg strict criteria, which is also used throughout the world today. And what we want to avoid or want to know about, if the morphology is 4% or less, anything more than 4% would probably go through as adequate. And there are a number of studies that actually showed that if the morphology is adequate, then the success rate with procedures like intrauterine insemination and IVF is better than if you have less than 4% morphology. Some specialized tests, the most common and what we used is a mixed agglutination reaction, or what we call the MAR, and that's where actually the sperm has got no problems in themselves, but they have sticky tails. So it's like trying to run a 100-meter race holding hands. So the sperm, although they are good, they stick to one another, and their performance in trying to get to the cervix mucus and getting to the egg, it's much more difficult. What are the treatment modalities available? If you have no sperm, make sure that you exclude retrograde ejaculation, where actually ejaculation takes place into the bladder, and these patients should be referred. I think to try and get a reason why there are no sperm, whether it's obstructive or whether it's non-obstructive, and the hormonal test here can be very helpful. If you look at sperm with motility less than 40%, these are the people that should also be referred to a fertility unit. And sperm manipulation here using IUI or ICSI are very valuable tools. If you look at morphology less than 4%, these patients should be referred if they do not fall pregnant within a reasonable time, and that ICSI or IVF can be used. The success rates would depend on the success rates of the fertility unit, but on average would be somewhere between 40 and 60% per cycle. If you have anti-sperm antibodies or the mixed agglutination reaction, intrauterine insemination or ICSI can really help. Steroids used to be used a number of years ago, but this is proven not to be of any value. If you look now at other treatment modalities like micromanipulation or the intracytoplasmic sperm injection, this is for really where you take out single sperm under 400 times magnification, and this is normally if there is very little sperm or you have to go the way of a testis biopsy. And if this is done carefully, the success rates can be approximately 50% per cycle, with a cumulative pregnancy rate of about 85% after 3 cycles. So to summarize, I think you should choose your words carefully if you deal with male fertility and you have to give the message. I think males are very often brought up with the saying, cowboys don't cry. Just remember the psychological impact. And I think the psychological impact on males who get the diagnosis of being subfertile or being infertile is actually much bigger than we think, and might even be more severe for males than it would be for females. And that comes from the thesis that was done by Wijnland Van Waart for a MA in psychology. Remember, we should treat patients as a team, and also remember that donor sperm would be one of the options if no sperm is available for use from the male partner. Now, communication, and I think this is unfortunately in Afrikaans, and those of you who can understand Afrikaans see that communication to avoid confusion is quite important. So if we look currently, what is trending, I think morphokinetics is actually where you take the little embryos, they develop, you take a picture of them every 15 minutes in order to see how they divide, when they should divide, and what they would look like, makes things a lot easier to identify the top embryo to be transferred. PGTA, or pre-implantation genetic testing for aneuploidy, to try and test embryos to see if they are normal, along with PGTM, which means pre-genetic pre-implantation genetic testing for monogenetic actually aberrations is something that you can actually do for specific conditions like cystic fibrosis or hemophilia, if that's important. Non-invasive PGT testing, where you actually use the culture medium that the embryos were cultured in to test without actually harming the embryo, like with PGTA, is something that is really currently trending. And also something about gene manipulation. There have been a number of experiments now where you can actually remove harmful genes, but that at the moment is only allowed for somatic cells. In other words, cells that does not get transferred to your offspring, at the moment not allowed for the genetic manipulation of cells or trends that can be inherited. So there was a case in November 2018 of a guy called Professor He Jiankui, who actually was the first person to do gene editing, but he was struck off the medical roll in China. But the experiment was actually very good in the sense that what he did is try to stop the transferring of HIV from the parents to the babies. But because of ethical concerns and lots of other arguments, this was ruled that it was not ethical, and he was struck off the medical roll. But this experiment might open a couple of doors in the future. The big debate is still on. But I think if this is actually done very carefully with a lot of research to be done, it can open some new avenues. So to summarize, I did say choose your words carefully, make sure that your psychological impact is attended to. I think remember that for those males with cancer, one can freeze sperm before treatment. Make sure that you know your status. And then recently, we've also opened our Wijnland Fertility Men's Health and Male Fertility Clinic in order to attend to males, as I think males have been neglected for quite a while, and we would be very happy to help people who need some support. Our slogan for our male clinic is now what we call Male Magic. Let's talk the male tale. Our email address is there. If there are anybody that's interested in this, you're more than welcome to contact us. Thank you very much. And this is our team at Wijnland Fertility.
Thank you very much, Dr. Van Waart. I was actually going to ask you, because I have seen recently that you guys have a male fertility clinic. And am I right? Are you guys out in Somerset, the male fertility clinic?
Yes, what we do is our clinic is actually in Stellenbosch, but we have an office which we recently started off in Somerset West as well.
Okay, great. So thank you very much for doing this talk. If anyone out there will have any questions for Dr. Van Waart, you can contact them on wijnland.co.za, go to their website, or I know they've got social media pages, you can contact them there, or you can even email me, and I will send the emails through to Dr. Van Waart. But they've got a great clinic established, especially for males, and that is a great start. You know, we're always wondering, what do you say to males? And I was saying to someone the other day that more and more men are actually contacting us for help, and which is great. So we'll definitely keep your details for that. So thank you for joining us today, Doctor. We really appreciate it.
Thanks for the opportunity.
It's a pleasure. Have a great evening. Thanks. Bye.
Thank you.